Hello, I'm Eric Strong, and today on Strong Medicine, I'm discussing Remdesivir. A month ago, everyone was talking about hydroxychloroquine as being the possible cure for COVID, which unfortunately hasn't panned out. But in the wake of trial data released last week, Remdesivir is all we're hearing about now. People are asking whether this will help our communities open back up again, and news about its clinical trials is shifting the world's stock markets. But will the story be any different this time around? I'll be talking about what Remdesivir is, how it works, what the trial data says, and what we should conclude from it all. Before I start, I want to be transparent about a conflict of interest. Several of my colleagues are working on Remdesivir trials. However, I have not directly spoken to any of them about their data beyond what's publicly available, and they have had absolutely no input in this video. They don't even know I'm making it. So with that out of the way, what is Remdesivir? Remdesivir is in a class of medications called nucleoside analogs. These drugs are structurally similar to the nucleosides that make up DNA and RNA. That is, the C, G, A, T, and in the case of RNA, U, that make up the base pairs within our genetic code. Other nucleoside analogs include acyclovir, which is used against viral infections like herpes and varicella, AZT, used against HIV, and even gemcitabine, a chemotherapy drug used in various cancers. Remdesivir is specifically an analog of the nucleoside adenosine. Some viruses, like Ebola for example, are classified as RNA viruses. RNA viruses use RNA rather than DNA to encode their genes. When an RNA virus is attempting to replicate itself within a host cell, an enzyme called RNA-dependent RNA polymerase is tricked into incorporating Remdesivir into the genetic code of the virus's offspring instead of adenosine, which results in a premature termination of the copying process, preventing replication. The enzymatic machinery that our cells use to copy our own genetic code has a better proofreading mechanism that can much more effectively distinguish Remdesivir from adenosine, resulting in human cells being relatively immune from the medication's effects. While most of the world hadn't yet heard of Remdesivir until COVID hit a few months ago, it's not a brand new medication. It was developed by Gilead Sciences during the West Africa Ebola epidemic of 2013 to 2016. However, that outbreak actually ended before the drug could enter human clinical trials. But Ebola struck Africa again in 2018, providing an opportunity to test it. From 2018 to 2019, a randomized trial of Remdesivir versus 3 other therapies was conducted. Unfortunately, an interim analysis found that 2 of the drugs, including Remdesivir, were not as effective as the others, and they were removed from the trial. While this might have been seen as a failure for the medication, it did help to create a track record of some experience with it in humans and provided some bounds on its safety profile. In other words, it demonstrated that the drug probably doesn't kill people itself. Fast forward to January 2020, SARS-CoV-2, then known as novel coronavirus 2019, emerges as a major threat to China and possibly the world. Scientists know that it will be much faster to repurpose an already developed drug for coronavirus than it will be to create a brand new drug from scratch. The novel coronavirus is an RNA virus that uses the enzyme RNA-dependent RNA polymerase, just like Ebola does. So Remdesivir was a logical drug to consider, its previous failure notwithstanding. This brings me to the trials. To date, there have been 3 of them that have released some amount of their data, all of which came out on the same day last week, which does not feel coincidental. All 3 trials involved adult patients with confirmed cases of COVID who were hospitalized with evidence of pneumonia. In the first trial, sponsored by Gilead, 397 patients to date have been randomized to receive either a 5 or 10-day open-labeled course of Remdesivir. Some of you may already see a problem here. Although this is being billed as a trial, there is no control group. Everyone got some amount of the experimental medication. Also, the study is not blinded, meaning patients know which course they are being given. The primary endpoint is improvement at day 14 by at least 2 points on a 7-point ordinal scale of disease severity that ranges from hospital discharge to death. The primary endpoint of categorizing the severity of illness has some degree of subjectivity involved. This is usually not a problem if patients and the treatment teams are both blinded to which course of therapy the patients received, but here they weren't. It's easy to imagine a subconscious influence of a patient knowing whether they got the short or long course of medication on their subjective sensation of shortness of breath, which is one of several factors in determining whether doctors give them oxygen, which impacts their location on the disease severity scale used in the study. What has the study found so far? The median time to clinical improvement was statistically the same in both treatment groups. So 5 days looks to be just as good as 10 days, which was spun as positive news. Except we don't yet know if either duration is more effective than no drug at all. That's the problem with the lack of a control group, where we are unable to compare the drug to something we already understand, which in this case would be no treatment. Now, if we knew for a fact that 10 days of Remdesivir was effective, then it would be helpful to know that 5 days was just as good, because that would save money, and more importantly, it would allow twice as many patients to be treated for as long as the overall number of available doses in the world remains limited. But at this point in time, this study doesn't seem to tell us anything. I say seem because the data hasn't been published or peer-reviewed. It's just information in a press release from Gilead. The immediate effect of which was primarily confusing the public due to 2 other Remdesivir trials being discussed on the same day. So now to the second trial, which was conducted in China and sponsored by the Chinese government. This trial, published online by The Lancet, is titled Remdesivir in Adults with Severe COVID-19, a randomized, double-blind, placebo-controlled, multi-center trial. So from that name alone, I'm already getting much better vibes about the design. This trial randomized 237 patients to either a 10-day course of Remdesivir or placebo. The primary endpoint was similar to that previous study, time to clinical improvement as graded on an ordinal scale, and there were a number of secondary endpoints such as mortality at 28 days, duration of hospitalization, and viral load. What they found was that there was no statistically significant difference between the Remdesivir and placebo groups when looking at any of the outcomes, primary or otherwise. At first glance, this looks extremely disappointing. However, there is a huge caveat to these findings. Because the trial was started relatively late in the course of China's infection curve, and because the public health measures taken there have been so effective at reducing new cases, the investigators were unable to reach their target recruitment numbers. They had to stop early because they just couldn't find enough patients to enroll. The consequence of this is that the trial was what is referred to as underpowered. This means that if Remdesivir actually does have benefit, there was a higher than normal chance or higher than acceptable chance that the trial would fail to identify it. So in summary, we can't use this trial alone in isolation to say that Remdesivir doesn't work. It's evidence against it, yes, but it's very far from conclusive. Now we have the third trial, the one that dominated the news last week. This is the ACTT trial. ACTT standing for Adaptive COVID-19 Treatment Trial. It was sponsored by the National Institute of Allergy and Infectious Diseases, which is currently run by Anthony Fauci, and which is part of the NIH. They randomized 1,063 patients to either 10 days of Remdesivir or placebo. The primary outcome is briefly summarized as time to recovery. But recovery here is not defined as you might expect. Now, when I hear a person with an infection has recovered, I'm imagining that they have fully returned to their previous state of health. But in this trial, they considered recovery to be either returning to previous state of health or being well enough for hospital discharge. And I can tell you that doctors will frequently discharge patients who are not close to their previous state of health. So, for example, if you were a marathon runner who contracted COVID severe enough to require hospitalization, were enrolled in this trial, and were eventually discharged, while you're still short of breath, still requiring home oxygen, and completely unable to return to running, it appears that the trial investigators would consider you to be recovered. I won't say this is a red flag per se, but it's definitely the first of several yellow flags about this trial. So having said that, what were the results here? The publicized punchline appears to be that the median time for recovery for patients randomized to remdesivir was 11 days, while those randomized to placebo recovered with a median time of 15 days. So the course of the illness was 4 days shorter. Although it was not the primary outcome measure, there was a suggestion of a mortality benefit, with remdesivir patients having a mortality of 8.0% and placebo patients having a mortality of 11.6%. However, this mortality benefit did not meet the conventional definition of statistical significance. That is, its p-value was greater than 0.05. Now, I strongly believe that we over-rely on p-values, and I don't like the idea of the dichotomous categorization of findings as being either positive or negative, so I would not write off the possibility of a mortality benefit. And if it's real, a 3% absolute risk reduction of death may not seem huge, but if we're talking about millions of patients, that's still going to translate into tens of thousands of lives saved. So, what were the strengths of the study? Well, like the Chinese study, it's a classic double-blind, randomized controlled trial, and one that is much larger and probably adequately powered. So, on the surface, this feels like a very robust trial. But I already mentioned one yellow flag and how they defined recovery, and unfortunately, there are two more known weaknesses to talk about. The first is that the primary outcome was changed after the trial began. So how it works when a scientist wants to conduct a clinical trial in the United States, and as far as I know, in most other countries too, is that the scientist has to pre-register all of the details of how the trial will be conducted and how its data will be analyzed before they have recruited any patients. The pre-registration process serves a couple of functions. First, it helps to ensure the trial is safe and ethical before any patient receives anything. But it also reduces something called p-hacking. P-hacking is a huge topic and has many different facets. But one form of p-hacking occurs when investigators in a study measure a huge number of different types of outcomes, such that by chance alone, one of them is likely to have a result that crosses the magic and arbitrary threshold of statistical significance. Then afterwards, the investigators can focus on just that one positive result and ignore all of the negative ones. By pre-registering the specific outcome that the scientists are primarily interested in, it makes it more obvious when they cherry-pick the one potentially randomly positive result from a long list of secondary outcomes. When the result of the ACTT trial were made public last week, a few people quickly noticed that the primary outcome that Falchi touted, median time to recovery, was not the primary outcome in the initial trial pre-registration. It had been changed somewhere along the way, and luckily, these changes are part of the public record. We can see that this change occurred on April the 16th, less than 2 weeks before Fauci announced the data. So what was the original primary outcome? It was ranking of disease severity on an ordinal scale at day 15, similar to the Chinese study. At first glance, that change seems kind of questionable. Here's one take on Twitter that resonated with me. Changing the endpoint mid-trial this way is like hosting a race for one destination, then declaring wherever you end up after running for an hour is the finish line. Now, alternatively, there are plenty of completely legitimate reasons to change the primary outcome mid-study. For example, Meg Terrell, a health and science reporter for CNBC, tweeted out this explanation from the NIH that she had reportedly been emailed. It basically says that not enough was known about the natural course of COVID when the trial was registered, and patients ended up taking longer to recover with or without the drug than the originally selected 2-week time frame. It further claimed that the change in primary outcome was made by people not having any knowledge of the collected data. That feels like a very reasonable explanation. Is it true? I have no idea. Given that there are literally billions of dollars riding on this drug, which means billions of dollars riding on this specific trial, I can appreciate why some people remain skeptical. For me, though, the biggest yellow flag for this trial is that all the information we have about it is only the punchline delivered via press release and press conference. There's no peer-reviewed published paper, and there's not even a non-peer-reviewed preprint. That's because the trial hasn't even been completed yet. All the information we've heard about ACTT is just based on a tiny fraction of data from an interim analysis. While a lot of the media doesn't seem to appreciate the significance of this, many physicians and scientists do. Now, I'm not saying, and I don't think any of these folks are saying, that there's something nefarious going on. Just that we can't make up our minds about the drug without being able to see the actual data. And how in the world can we properly counsel our patients on its risks and benefits? The medical literature is overflowing with trials that have positive conclusions, but which have a ton of nuance buried in the tables and the figures. There will likely be much nuance buried in the Remdesivir data that will partially mitigate the sense of optimism we heard from the White House last week. Let's examine two sets of specific words that Fauci used during the White House meeting.
What it is proven is that a drug can block this virus.
So Fauci is saying that he accepts this interim analysis of an as-of-yet incomplete trial as proof. That's a bold statement, which in my humble opinion is not yet adequately supported. And then here is what he says later.
And all of the other trials that are taking place now have a new standard of care.
That's a really critical line, claiming that Remdesivir is now standard of care. What does that term mean? The standard of care for a disease is the set of treatments that a reasonable physician would be expected to provide to a patient. It's determined by professional societies, clinical practice guidelines, and really by the consensus of the entire medical community. It's not up to one person. So Fauci, he doesn't actually have the authority to dictate that Remdesivir is the standard of care for COVID. However, by very publicly claiming it as such, he's putting future investigators of COVID treatments into a bind. When a scientist designs a clinical trial of a drug, in order for the trial to be considered truly ethical, the drug should be compared to something not known to be inferior to the standard of care. So for diseases that have no known effective treatments, like COVID, the study drug gets compared to placebo. That's what was done in the ACTT trial. But once a disease gains an established treatment that's better than placebo, all future studies of other treatments should be compared to that established treatment. So in this case, that means future trials of COVID cannot be a simple, clean experimental drug versus placebo. Instead, the options will be experimental drug versus Remdesivir, or alternatively, experimental drug plus Remdesivir versus placebo plus Remdesivir. So for one, by prematurely declaring Remdesivir the standard of care, if the ACTT trial's data doesn't conclusively prove the effectiveness of Remdesivir, we may never really know if it truly works. It will be close to impossible to start a new placebo-controlled trial of Remdesivir at this point. But even more broadly than that, since any future treatments will end up being compared to a treatment of unknown efficacy, it may not even be clear how effective they are either. So what's the real takeaway in all this? We have information on 3 trials. We have a press release by Gilead that more or less told us nothing, a peer-reviewed published trial that showed no benefit, but which was underpowered due to an inability to recruit a sufficient number of patients, and a modestly encouraging press statement given during a glorified White House photo op. So in summary, the jury on this, it's still out. Until we can see the data, we should not make up our minds. I remain hopeful that remdesivir will turn out to have some benefit, but I would not count on it being a miracle drug. Compared to antibiotics for bacterial infections, antiviral drugs for acute viral infections have a poor track record of success. For now, the only interventions that are known to have a significant impact on our risk of death from COVID are respiratory support for those with pneumonia and social distancing measures to prevent catching the disease in the first place. Thanks for watching, and stay safe.